just want to welcome everybody. This is an MS Views Now program. We started this at the beginning of COVID, and is to update everybody monthly on what is going on with COVID-19 and multiple sclerosis. Okay, and when we actually began this, it was just it's nobody knew anything. All right, and here we are, and I'm watching this, and I'm involved with this every single month, and hearing different professionals like Mitzi Williams speak about it, and we get to see the evolution of what's been going on. So I'll talk to you more about that in a minute. But for those that don't know, I doubt that anybody's on here that doesn't know, but my name is Stuart Schlossman, and I am an MS patient and am president and founder of MS Views and News. All right, and next we have our sponsors for tonight. As soon as I see them online, I can read them all out to you. We have Bristol-Myers Squibb, we have Genentech, and we have Biogen, and we want to thank them, of course, for supporting this program. Tonight's guest, Mitzi Williams. All right, Mitzi Joy Williams. She's part of the Joy Life Wellness Group in Atlanta, and she's president, she's founder of that, and she's doing a tremendous amount of work in that area. And there's, if anybody is in the Atlanta area or within driving distance and on here tonight, I suggest that you make an appointment to go see Mitzi. All right, and she'll definitely help you out. All right, so for tonight's program, it is about COVID. All right, it's about COVID-19 and multiple sclerosis. We're going to keep our topics, relevant to that. Please keep your questions if you have any relevant to COVID-19 and multiple sclerosis, or what Mitzi is speaking about. I say Mitzi, Dr. Williams. Sorry about that, Doc. All right, and so Dr. Williams is going to be speaking for about 25 minutes. Then we're going to do Q&A. And for anybody that has questions, at the top of the scroll bar on the right side of your screen, there's an orange rectangle with an arrow in it. If you would click on that, you could type in your questions, okay, or questions, whatever you want, and then we will get to those as well. All right, so I'm going to shut down from this. I'm going to let Dr. Williams speak for 25 minutes, and I will be back, okay? Thank you very much, Dr. Williams.
Awesome. Thank you so much, Stuart. Thank you for inviting me to be a part of the program. And I'm looking forward to talking to everybody a little bit about COVID-19. I've just got a couple slides. I'm not going to give you a full hour lecture, but try to hit some of the high points, some of the things that we've learned. And hopefully, I'm sure we'll have some time for some great questions at the end. So this is our disclaimer. Whenever I give a talk about COVID-19, I've got to give a disclaimer, because really the data and our understanding of COVID-19 is very dynamic, right? So it changes on almost a daily basis. So certainly the information that I'm presenting is what is some of the most current information. Probably by the time I present some of it, it may be a little outdated, but absolutely this is for educational purposes. And if you have any specific questions about your condition, your MS, and vaccination, you definitely should talk to your doctor about those. All right, so we already know, but I'm going to review it quickly. What is COVID-19? All right, so it's an infectious disease caused by the newly discovered coronavirus. There are other viruses in the same family that we've heard of. There was the SARS virus not too long ago, where everyone thought that was going to be a pandemic, and it actually wound up not being as severe as we thought it was going to be. And then there's a Middle Eastern respiratory virus. And this virus, the first outbreak that was recognized was in Wuhan, China in December of 2019. And here we are over a year and a half later, still in the pandemic with numbers on the rise. So I think this is important to underscore. So anyone can be infected with COVID-19. So initially in early 2020, the people that were most highly being affected were those who had other medical conditions, those who, had compromise of their immune system, those who were elderly, etc. But over time, as we've seen the virus mutate, right? So we have now all these different variants. There's a Delta variant. Stuart talked about the Colombian variant. And now with all these variants, we are beginning to see more healthy people affected. We're also beginning to see more children affected. So I think, the most important thing is that certainly if people have prior medical problems or are elderly, which elderly is a relative term, that was initially, those people are still being affected, but now we're seeing younger people, now we're seeing healthy people, now we're seeing children more affected. So anyone can potentially be infected with COVID-19. So, real world data, right? So, when this first happened, nobody knew what was going on. The virus had so many different side effects. We really couldn't understand, what was going on in the general population. And then when you talk about a population of people with MS, which is much smaller than the general population, it was really a matter of a lot of us in the scientific community literally getting on calls every week with our colleagues in Europe, in the UK, in Australia, and all of us would just kind of talk about our experience. And so out of that experience, several registries have developed, and these registries have helped us at least find out more about the trends of COVID-19 in the MS population, more about how the medications for MS may increase or affect risk for infection, and also things about people in general with MS and COVID-19. And so this is just a list of some of the registries. So there is the Covicept registry, which is in France. There's the Italian registry, which are the earlier registries, especially the Italian one, because they were adversely affected by COVID much earlier, before the wave came in the US. There is the Global Data Sharing Initiative, which is a really amazing collaboration of 21 different countries. And then there's COVIMS or COVI-MS, and that's the North American registry here in the US, and there are about 2,000 folks in that. And then there's a Swedish registry, okay? So this is just kind of listing how much data we had. And literally, I remember when the French registry came out with data about like the first 50 or so patients. So obviously they have over 400. The Italian registry has close to 850. The global initiative has about 1,500, and the COVID-MS has close to 2,500. And so basically the thing about these registries is that most of these are people who were just diagnosed or who were diagnosed with COVID-19 and who also have multiple sclerosis. So what have we learned from some of these registries and some of this data? So certainly some of the risk factors that lead to worse outcomes in people with MS are very similar to the risk factors that lead to worse outcomes in the general population. So certainly older age. So we're thinking age over 60, which 60 is not old. I'm not saying 60 is old, but over 60. Certainly people with higher levels of disability. So people who have more disability from their MS, higher EDSS scores, which is our disability scale that we use in research and also in some of our clinical trials. So if you have more walking disability, et cetera, you may have a risk for a worse outcome. The men, unfortunately, tend to do worse, and that's something that you see in the general population as well as in the MS population. If people have progressive MS, they tend to do a little bit worse, and often if people have progressive MS, it kind of often goes hand in hand with higher disability, so those two are correlated. Also, we've seen independently the obesity increases the risk for poor outcomes with COVID, and that is also a factor that we see in the general population as well as in the MS population. Heart problems, again, in the general population and the MS population. And interestingly enough, also seen in the general population, but described particularly in the North American MS registry, is that those who are Black or African American tended to have worse outcomes. And we'll talk a little bit more about that in one of the upcoming slides. So what do we know about minority populations and COVID-19? Certainly when we look at the general population, populations that were adversely affected, especially here in the United States, were people who were Black, people who were Hispanic, and Native American. So these were populations that were devastated by COVID-19, often because many people have comorbidities and other health issues. But this was a breakdown from the COVID-MS registry, and there were about 194 Black people with MS versus 421 white people with MS. And the Black people were younger when they were diagnosed. Many of them were non-smokers. Or never smokers. They often had a shorter duration of their MS, meaning they hadn't had MS as long as their white counterparts. They had relapsing disease. Many of them did have comorbidities, which are other conditions, health conditions such as hypertension, diabetes, high cholesterol, etc. And we see that hypertension and severe obesity were the top two comorbidities that people had. And because of all these issues, we saw there was an increased odds of hospitalization, so 47% higher risk for hospitalization in the Black population, and increased risk of ICU admission and or ventilation, meaning having to be on a breathing machine to help breathe because of the severity of the respiratory symptoms from COVID. So again, minority populations tend to have more difficulty. All right, and then what else do we know about real world evidence with MS and COVID? Our understanding of how to treat MS has also evolved, so again, there are different ways that we gain information about how to treat certain conditions. And this pandemic has been probably one of the most challenging things that we've ever encountered in our lifetime in the scientific community. And so what we call real world evidence, which is things like these registries where people are registering and we're finding out information in real time, can help inform our treatment decisions. And so this slide just tries to demonstrate how things have changed over time. So in early 2020, everyone was very concerned in the neurology field about the treatments that we use for MS. Were they going to put people at increased risk? Did people with MS, just by nature of having MS, were they at increased risk for developing COVID-19 infection or having poor outcomes? And so in the beginning, we were concerned about, do we need to stop medications? Do we need to pause medications? Do we need to change the frequency of medications to try to prevent infection? And what we found over time from that data is that for the most part, people with MS, just by nature of having MS, did not increase the risk of having COVID-19 or being infected with COVID-19. And we also found that most people on most of the disease-modifying therapies also tended to do well, and they had pretty mild infections if they were infected, and there weren't as many deaths as we anticipated, and people who had poor outcomes were associated with those risk factors that we talked about that were very similar to what we saw in the general population. And so what we found was that it was important to actually maintain people's disease-modifying therapies, because when we stopped or interrupted their therapies, their MS would become active. So most DMTs do not increase the risk of symptomatic COVID-19 infection, nor the risk of severe COVID-19 infection, with the exception of our B-cell therapies, which would include rituximab, an off-label treatment for MS, as well as ocrelizumab. There was some data that suggested there was slight increased risk for poorer outcomes. So not that it increased the risk of infection, but that people may have had more hospitalization if they were taking those particular therapies and they had MS and they developed a COVID-19 infection. So all of that to say, most people who were taking disease-modifying therapies and who developed COVID-19, what we found from the registries is that they pretty much had a mild severity of disease. Most of them weren't hospitalized. In the COVID-CEP registry, which is the French registry, there was an association between some of the disease-modifying therapies and actually having lower COVID-19 severity. And in the French registry, there was a reduced risk for severe COVID-19 for most of the disease-modifying therapy. The COVID-MS, which is a North American registry, the data suggested that the highest death rate occurs for people who actually were not on disease-modifying therapy. So those who were not being treated for their MS actually had more severe outcomes if they developed COVID infection versus those who were actually on treatment. And then, kind of the last takeaway, but there are some exceptions, which we talked about, the anti-CD20 therapies, which are rituximab and ocrelizumab. We also have ofatumumab, which is a newer drug, but obviously that just became available in the past year. So we don't have as much information about COVID-19 with that medication because it's brand new. So what can we do to protect ourselves, right? So again, these are things that everyone was very, very vigilant about doing. I think that, as the vaccinations became available and as things seem to be calming down some, we may have gotten a little relaxed. But as the numbers are going back up, right, we're seeing increased numbers of COVID-19. The new Delta variant is suggested to be significantly more infectious than the prior variants. And so there was an example that suggested that the new Delta variant is as contagious as the chickenpox. And I remember when I was a kid and I had the chickenpox and I went to the doctor and I said I had the chickenpox, they took me straight to the back. They didn't want me to see anybody in the waiting room. They didn't want me to be near anybody because they didn't want anybody else to get it. So if that gives you an idea of how infectious the new variant is, it reminds us and underscores the importance of continuing or restarting to do some of these things that we used to do, such as wearing our masks in public, trying to social distance as much as possible, making sure that we're washing our hands, right? In the beginning of the pandemic, everybody had these songs that they would talk about, which equaled 20 seconds, a chorus of this song or a chorus of that song, and that would be your 20 seconds to wash your hands. And also to try to avoid crowds, right? You know, a lot of my friends were talking about a big concert in Chicago, Lollapalooza, and there were wall-to-wall people, right? And so we'll see hopefully how people do from that. And then I think the next thing that we can do that we couldn't do at the early part of 2020 is get vaccinated. So a little bit about vaccination against COVID-19. These are the guidelines for the MS Society and suggest that basically most people should get vaccinated, okay? The vaccines are considered safe. We have 3 that are on the market now here in the US. We have Pfizer, we have Moderna, and we have the Johnson & Johnson vaccine. 2 of those are 2-dose vaccines. One of those is a 1-dose vaccine. And so most of the vaccines are safe to use with our disease modifying therapies. And then, you know, the other piece is just thinking about kind of the global perspective, you know, and our ability to help make our whole environment safer if we begin to vaccinate. If we look at the cases of COVID-19, you know, so vaccination does not prevent you from ever getting COVID-19 again, right? So it doesn't mean 100% that you can't get COVID-19, but the goal of vaccination is to hopefully prevent it, but if not, to try to decrease the severity. And so when we look at many of the deaths that we're seeing, many of the severe cases in the ICUs, most of them are people who are unvaccinated, right? So the vaccines do work. The vaccines do help decrease the transmission of COVID-19 and also decrease the severity for those who do develop COVID-19 vaccination after they're infected. We don't know a lot about boosters, right? So there's a lot of questions about will people need to get a booster shot every year like they do for the flu? And the answer is the jury is out. It's a possibility because there is some suggestion that the effectiveness may wear off over time. But certainly we're awaiting, you know, recommendations from our health authorities about when we should be doing that, if and when we should be doing that. So one of the important things I think is to have valid sources of information. And Stuart was actually gracious enough to come onto my podcast a couple of weeks ago and talk about good sources of information. So there's a lot of information about there. A lot of information out there about COVID-19, about vaccinations. Everybody's got all these numbers, but it's important to look for credible sources of information, meaning information that is vetted and looked over by health professionals and other people in the community. So this is just kind of a list of places in the MS community and broadly that you can look at and find credible sources of information based on scientific facts. So the CDC, the World Health Organization, I've got MS Views and News in there, of course, because Stuart delivers great educational programming. We have our National MS Society, the MS Foundation, the MS International Federation, and the Multiple Sclerosis Academy, which is in the UK. So, you know, if you're seeking information, just try to make sure that you're balancing your information with credible sources. You know, and not just necessarily looking on Facebook or Instagram, you know, for all of your news and all of your information about COVID-19. Now, we'll switch gears and talk a little bit more about vaccination. So there are over 342 million doses of COVID-19 vaccine that have been given, and that's through July 26th of this year. The most common side effects that people had were some redness or pain at the injection site, which is usually in your arm, and oftentimes people may have had side effects after the second dose. So if they got a 2-dose vaccine, the first dose, many people said they did fine, didn't have any issues except for the pain at the injection site. But with the second one, they may have had symptoms like fever, headache. Some people had tiredness or muscle pain or chills. I had my vaccine, and I unfortunately developed COVID last year, and I had a pretty severe case of COVID. And so with my vaccine, I actually had symptoms with my first shot and not with my second one. So I had some chills and things like that. But those are the most common side effects. They usually start 12 to 24 hours after the vaccine is given, and they may last about 24 hours and then go away. And that's basically the immune system ramping up and responding to the vaccine to be able to protect you in the future from having more issues. Next slide. So this is a podcast that I did recently with a couple of my colleagues, Dr. Katil Ramahan, who's in Florida, and Dr. Robert Shin, who's in DC. And so we talked about COVID vaccination and talked about some of the recommendations. And I thought there were some good points out of that program that we could bring out here. And so what we discussed is that COVID-19 vaccines are, for the most part, safe for people living with MS, whether they are on or off their disease-modifying therapy. And it's important for the prevention of COVID-19 and the prevention of severe COVID-19. You know, one of the big questions is, can people mount an antibody response if they're taking disease-modifying therapies? And certainly what we found from the data is that with some of our disease-modifying therapies, the response can be diminished or decreased. However, even for our therapies, let's say that affect our B cells, in order for us to develop immunity to any type of vaccine or illness, it requires both a B cell and a T cell response. So just because one response is not optimal doesn't mean the other response is not working properly. And we still don't know quite what that means in terms of how immune people are, but certainly we know that the whole immune system response is not wiped out with most of our therapies. There's a lot that we don't know in terms of the timing. You know, initially when the vaccines were scarce and it was difficult to get scheduled, I remember literally sitting at the computer trying to make an appointment, and by the time I typed my name in, it was gone. You know, and so when we were in those circumstances where it was difficult to get appointments for vaccination, we always recommended that people get the vaccine as soon as possible, right? Because we didn't want you waiting around trying to wait for this optimal time and then you couldn't get it. Vaccines are much more widely available now. So certainly always discuss with your doctor about if there's a timing that may be appropriate for you with your disease modifying therapy. Oftentimes it's easy to get the vaccine before you start a new therapy, but certainly if you're on in therapy, talk to your doctor. They may not want to interrupt your therapy and risk your MS getting worse in order for vaccination, but that is an individual decision with you and your healthcare provider. And finally, this is just kind of an infographic with some of the information that we talked about that I thought really gave a good explanation of some of the key points that vaccines are safe for people with MS on DMTs or disease modifying therapy. They prevent COVID-19 infection or severe COVID. And that you can make some immune response on all of our therapies, even if the immune response may not be optimal. But vaccination is absolutely critical to try to end this pandemic. You know, we were talking about masks, and Stuart and I were just remarking that we had all these masks, and we were like, man, we're not gonna need these things. And I was like, you know, now we realize we're probably gonna need them for a very long time. But certainly at the end of the day, it's important to discuss with your healthcare provider, you know, especially if there's any concern about interrupting your therapy. And again, the issue with vaccination and disease modifying therapies is not that you would potentially be at risk for more harm or side effects, but that maybe the response would not be an optimal response and you may not be fully immunized. So, there's not a risk for poor outcomes in terms of side effects or problems with the vaccine. It's just we want to make sure that you are fully immunized and that you have an adequate response against the COVID-19 virus. And I always throw a slide in there about the National African American MS Registry, which is a new registry where we're trying to gain information about MS in the Black population here in the US, and that's the website. and this is how you can find me. I am the nerdy neurologist, and my practice here is in Smyrna, Georgia, which is right outside of Atlanta, and it's called Joy Life Wellness, like my middle name, Dr. Mitzi Joy. And finally, I end every presentation with this slide that says, all I need is peace, love, and a freaking cure for multiple sclerosis. Thank you all so much for your time and attention, and I will have Stuart come back up and we will dig into those questions because I know you've got a ton of them.
Great, and I do actually. So while you were speaking, thankfully with that great information. Sorry, I'm a little tongue-tied here tonight. It comes from only having 3 hours of sleep last night. All right, but
Oh, goodness.
blame it on the airlines. They don't pick up their phones right away, and they want to call people back in the middle of the night. Okay, so anyway, that was great. Thank you very much for all that. That was great information. Some of the questions that I have for you, though, might make you say something again, only because, you know, I'm not totally functional, and I although I heard everything, I didn't absorb everything. All right. Okay, great.
Repetition is good.
Exactly. All right. So firstly, for anybody that has any questions, and you know, you might hear the question, I might be saying it, but if you see in about 10 minutes from now that I haven't asked it, you may want to go on there and type it in, and we'll see if it's been asked. I won't say it again, but I will be able to call it out if it has not been asked. All right. So one of the first questions that I have, and this comes from an anonymous source, is how do you know if the vaccine even works? And is there a test that can be taken for this?
Yeah, so it's an excellent question, right? So, you know, there's not really a way to test each individual person to say, this is your immune response, you are fully immunized and you won't get COVID-19, right? But the reason that we know it works is because there were very large clinical trials, right, prior to any of the vaccines being released to the public, right? And I know people have a lot of questions about them being approved by the FDA for emergency use. But certainly there were very large clinical trials. So for instance, with the Pfizer vaccine, there were close to 30,000 people enrolled in that trial, and about half of them received the vaccine and half of them did not. And with the Moderna trial, there were close to about 20,000 people. So, you know, what therapy have you had, you know, 30,000 people take before it even got approved, right? And so basically those people are monitored over time for side effects. And what we know is that of the people in the original trials, it certainly was proven that the risk for COVID-19 infection was significantly decreased. And of the people who were vaccinated, they had less severe infections. Other piece to that is that you also get data or information from when a medication or therapy is released into the general public, right? So that's that real world evidence, like in those registries that I talked about. So what we see also is when you look at hospitalizations, because these things are still reported, and I have good friends who work in health departments who said that, you know, the COVID-19 calls were slowing down and now they're working 7 days a week again, you know, to call out these results. And so what you see is that even with the hospitalizations, they can report if people are vaccinated or not. And what they're finding is that with the severe hospitalizations, and especially with a lot of the deaths, many of those are in unvaccinated people. So, you know, they are definitely being more affected than those who are vaccinated. So that's basically how we know it works. But there's not a way really to look at an individual person and take some type of test to say that you developed this response and you are fully immunized.
Okay, thank you.
That's a good question.
All right, so that leads up to the next one. So Diana has a question and a comment. She writes, I have a comment. I've been told by some MSers the reason they won't get the vaccine is because of how fast they were made available. As you know, the DMTs that, you know, for multiple sclerosis go through several phases and years before being approved. What can I say to those people?
So what you can say is that these are absolutely different and dire circumstances, right? You know, so there's a difference between kind of having the, I won't say time, having the time, you know, to look at. So most of our clinical trials run for disease modifying therapies run for 1 to 2 years, and then after that, data is analyzed, is submitted to the FDA for approval, et cetera, et cetera. If you think about the average medication. With COVID-19, with the pandemic, we kind of almost had the perfect storm in a bad way. So you've got millions of people that are affected by a condition. You've got many thousands of people who are willing to be volunteers to be in these research trials. You have companies and countries that are putting lots of money behind the research because they want people to stop dying. And so you kind of wind up with this perfect storm of you got money for the trial, which money is an issue. You got people for the trial, right? You got thousands of people at one time, and you got millions of people where you're seeing the outcomes in the real world. And so, yes, it was developed quickly, but the other thing to keep in mind is that many of the components, right? So we think about the mRNA component of the vaccines, much of that science has been worked on for decades, right? So the science is not all new, but it happened that the science was there, you had the population there, the people there that were being affected, and you had the money to get the job done. And so when you add all that together, something happened where it could be done much more quickly than we normally would have seen with the average medication or average therapy that wasn't killing millions of people around the world.
Okay, thank you. Hey, if my signal breaks up a little bit, it's because we're having a tremendous thunderstorm here. So I will,
No
I'll get through it as best I can. All right, Joy is making a statement. France, Israel, and next month UK will offer a third dose for immunocompromised, including those on anti-CD20 meds. When will that happen here?
I wish I knew. I do not have my crystal ball yet, but certainly there is a lot of talk about booster shots, meaning an additional shot, like how we get the flu shot every year. The CDC has not really given us guidance on when that will happen, what groups may be exposed to that first. We don't really know if it'll be a totally separate formulation or if you'll just get one of the shots that you had before. There's a lot that we don't know, so I don't have a good answer to that. But I suspect that we will be hearing more about booster shots in the coming months.
So Pfizer's been doing a lot of talk about getting that third shot now, and I didn't know if they're just pushing to get it done or if it was absolutely needed, and I guess we'll find out in the months to come. All right.
Yeah, but that's a great question. But I would say this, Stuart, we are seeing that it does seem like the effects or the immunity wears off over time, right? So, for people who have been vaccinated, let's say back in October or right when the vaccination first became available, some of those healthcare workers, now we're seeing some of those people getting mild COVID-19 infections. So there is some evidence that the immunity does wear off after time. So I suspect that we will need some boosters at some point.
Somewhere else I've read recently that I believe it was Pfizer who said that after X amount of months that it's not 95% effective anymore, but only 84% effective.
Mm-hmm.
So is that going to continue to go down? And when is it that it becomes so ineffective that you definitely have to get another shot? I mean, that's, I guess, a great question too.
Yeah, it is. And the honest answer is we don't know, right? So, this again is very unprecedented times for the scientific community. But I do think the encouraging thing is that we really see the global scientific community sharing information at a rate that I've never seen before, right? So usually everybody's protecting their information till they can get it published, but everybody's calling everybody, talking to everybody, conferencing with everybody, and hopefully we'll get some more information about when those antibody levels go down and we absolutely need to get revaccinated.
Okay, so that being said about those that are vaccinated, what about now for those that got COVID early on and were told that they have enough antibodies now to fight this? Is there any knowledge though on how long their antibodies are actually going to last, or is not yet known either?
So there's some preliminary data, right? So in the beginning, when people's antibodies were being tested regularly, there was some preliminary data that if you had an infection and you had antibodies that anywhere from 3 to 6 months after you develop those antibodies, they could be gone, right? So there's some people who, would get an infection, they get antibodies tested, they'd be, positive for immunity antibodies, not necessarily active infection antibodies. And if you test them again, 3 or 4 months later, the antibodies are gone. So somewhere between that 3 to 6 month window, some people obviously is a little shorter than that, some people a little longer than that, because there are people who've gotten reinfected within 3 months of their first infection. But certainly in terms of natural immunity, it does not mean that you don't need a vaccine, right? So that I think is a myth, right? Because the natural immunity often does wear off over time. So it is generally recommended that even if you've had COVID, that you get vaccinated, but at least 90 days after your active infection is cleared up.
Okay, great. So I'm going to group a lot of different people's questions into one thing. Similar
Yeah.
to drugs similar to Ocrevus, the B cell depleters. Can you re-explain or tell us again how that might affect their vaccinations?
Absolutely. So when we develop immunity to a virus, to a vaccine, or something that we're exposed to, there are two main types of cells that are involved. There are B cells and T cells, right? There are lots of cells involved, but the main ones that we discuss are usually B and T. When we wipe out one type of those cells, you may not be able to mount an adequate response to whatever that thing is you're introduced to, whether it is COVID-19 itself, whether it is the vaccine, etc. And so the concern with those medications is that when you have taken one of those medications and it's wiped out one type of your cells, that when you're exposed to that vaccine, you won't be able to get the appropriate immune response, your body, because your body doesn't have the cells there to mount that response. However, there are both types of immune cells involved in the response. So it doesn't mean that you have no response. The response may be decreased because you're missing those cells, but you still have the other types of cells, the T cells, which can still mount a response. There's a lot of researchers that are looking to see what that means in terms of actual clinical outcomes, right? So if you don't have B cells, but you got T cells, does that mean you're immune or does it mean you're not? The honest answer is we really don't know kind of what that means in real time in terms of your immunity. But what we do know is that even if you're taking those medications, you still can mount some type of immune response. It just won't be as good a response as if you hadn't had those cells wiped out.
Okay, thank you for that. All
Hopefully
right,
that
so
made sense.
it does, but to many and doesn't to others. So, all right.
Okay.
To just for me to say a couple of comments here. There are people asking questions that have nothing to do with tonight's topics, and I'm going to have to say again that we are unfortunately not going to be able to get to those questions. There are too many that are relative to tonight's topics, okay? And another thing is, all right, so here's another general question for somebody else that's asking how much, let me get this again, how much time is needed before or after the Ocrevus infusion and vaccine injection? That was asked by Mark.
Yeah, so again, the important thing is always to talk to your healthcare provider, right? So there's been a lot of talk about this timing of medications, that we delay medications. In a perfect world, when all the stars align, it'd be great if you could get vaccinated before you started a disease modifying therapy, especially one that affects your B cells or affects your B and your T cells in terms of like depleting them or wiping them out. So that would be great, but it doesn't always happen like that. Many people have different kind of ways they look at it. Ideally, if you got the vaccine, let's say 6 weeks before your next infusion, right? Because basically what happens is the infusions wipe your B cells out, and then over time they grow back, which is why you need another dose so we can wipe them out again. So ideally, if you got it like 6 weeks before your next infusion, that would be great. But again, the main thing is to talk to your physician about it, because oftentimes I've been recommended that people get the vaccine when they can get it. And if we can't get the perfect timing, then that's fine. But we want them to get it because we don't want them to get COVID.
Okay, thank you. Quick question. Diane is asking, my husband and I just got the 2 Pfizer vaccines. If a booster is needed, is it known that will be a 2-shot vaccine or just the one?
We don't know that yet.
Okay, thank you.
I suspect it will be one, but I don't know.
Okay, thank you. All right, a few people asking if there's any different risk associated with getting vaccinated.
So, so again, nothing is without side effects, right? So, certainly there have been some stories about some issues with some rare side effects with the vaccines. There were some people with the Johnson vaccine that developed certain types of blood clots. There have been some folks who have developed some heart issues with one of the vaccines. Also, a couple of people that developed Bell's palsy, which is kind of weakness on one side of the face, as well as Guillain-Barré, which is a neurologic syndrome where people have weakness that starts in their legs and kind of spreads up their body. And so I think the thing to say is that certainly nothing is 100% completely safe with no issues. But the incidence of these side effects is extremely, extremely rare, right? So if you think about the 10 cases of blood clots came out for the Johnson and Johnson, it was out of like 6 million people, right? So you have millions of people with very rare side effects. And if you think about the same thing with many of our disease modifying therapies, some of them have extremely rare side effects, but we always weigh the potential risks of developing severe COVID-19 and dying or be hospitalized with the very rare side effects of the vaccines.
Okay. So again, in person is thank you for those answers so far. How effective is the vaccine while using a DMT?
So for most DMTs, the vaccine is effective. There are no issues with the vaccine. Again, there's not a way to test individually how immune a person is. The other thing that we don't know from our large trials is we don't know how many people with MS were in those original trials. So certainly we hopefully will find some information out about vaccines as these registries are continuing to go on. I'm sure they're collecting information about people who are being vaccinated with MS, but we just don't have a lot of data to be able to say, how immunized a person is. However, there is some data with some of these medications and other vaccinations. So we often recommend the flu vaccine for many people living with MS, for all people living with MS, really. And so from a lot of their vaccination data, people were able to mount good immune responses to, for instance, the flu vaccine. So it is suggested that you would also be able to mount a good immune response to the COVID-19 vaccine.
Okay. And I have a question for you before I get into everybody else's questions
Yeah,
again.
go for it.
How diverse are the clinical trials with different ethnic backgrounds now compared to when we first began with COVID?
In the COVID trials or in the COVID trials? So yeah, they actually were pretty diverse. So so if you think about the Black population, there's probably about 10 to 13% African Americans in the trials. Now, that's a good number if you look at the general population. If you try to think about it in terms of the groups of people who were most adversely affected by COVID-19, which was largely African Americans and Hispanic Americans, the numbers would be low, right? Because they make up a lot of the cases. But if you look about the proportions of the general population, there's about 10 to 13% enrollment, which is great, which we probably haven't seen for any of our clinical trials. So there was good enrollment of minorities in these clinical trials for the vaccine.
Okay, great. Thank you. All right. The next one is third booster shots for those on B-cell depleting medications. How safe is that?
We don't know because it hasn't been done yet.
Okay. All right. Next, for a person on the Ocrevus infusion, what is the particular timeline for a person to repeat infusion taking the AstraZeneca?
I don't know because AstraZeneca is not approved here. But again, when we talk about timing, the key thing is that people need to get vaccinated when they can get vaccinated, if at all possible. You can always talk to your physician. I said, as vaccines have become more widely available, there's not as much of a I won't say there isn't as much of a demand as there was in the beginning when we had trouble finding appointments. So, talk to your doctor about it. Oftentimes I've told people, wait a couple weeks after your infusion, or if we're a couple weeks before the next one, we can do the vaccine then. But there's not necessarily a perfect timing for getting vaccination. The key is to get vaccinated.
Thank you. Mark Roberts wanted me to say hello to you. All right. So
Hi.
he screamed this out. He He shouted out loudly in an email that was sent, so I wanted to let you know, all right? Okay, next, for anybody that wants to know how they can see this program again, it's pretty well known. We have our YouTube channel, okay, and it'll be published on our YouTube channel in a couple of weeks, not a couple of weeks, a few days from now. Don't have to be a couple of weeks anymore. In a few days from now, it'll be published on our YouTube channel, and you can watch it again, all right? So just, send an email to me directly if you need to and ask me if it's been published, or just go to our website, www.msvn.org, MSVN, Multiple Sclerosis Views and News. No, it's msvn.org. And on the top of the page, the side of the page, there are banners for you to click on to reach our YouTube channel. Okay, that's for you, David. All right, next we have K. Some MS patients are on IVIG therapy as protection against COVID. How does IVIG protect these patients with low cell counts after their MS therapies like Lemtrada?
Oh, wait, say that one more time. Read that one more time.
Some MS patients are on IVIG therapy as a protection against COVID. How does IVIG protect these patients with low cell counts after therapies like Lemtrada?
So IVIG basically gives additional antibodies to try to protect people, MS patients, from infection. It's not something that is as widely used as it was when I first started practicing, maybe about 15 years ago. Some people do continue to give IVIG, but we really don't have a lot of data about that being given just as maintenance after people have received immune cell depleting therapies. And I really don't have any information about how that may protect against COVID-19 infection, honestly.
Okay, thank you. I'm not too clear on this question, but Bruce says, Dr. Williams said B-cell DMT affect outcomes of COVID, not vaccine effectiveness. Could you comment further on this?
No, so I said it does affect vaccine effectiveness. So the immune response is not it's not a normal immune response if people are on B-cell therapies and they get vaccinated, because some of their immune cells are depleted. So there is an effect on immune cell response when people get vaccinated. And also there is data that suggests that there were slightly worse outcomes from COVID-19 infection. So what I said was that taking a B-cell depleting therapy does not increase your risk for COVID, but it does increase the risk for possibly worse outcomes if you were to get COVID. So there were more hospitalizations, particularly for people who were taking rituximab. I think the risk of mortality was a little bit higher, but I don't think we saw that as much with Ocrevus. But there were more hospitalizations for those who were taking B-cell therapies who developed COVID-19 infection, and B-cell therapies do affect the vaccine response.
Okay. If
I did say that, I misspoke.
Okay, thank you for that. Now, if we were not to be doing any DMT at all and our immune system being hyperactive, yes, everybody, we have multiple sclerosis. Our immune systems are hyperactive, not underactive, all right? But if we were not doing a DMT, would we fare better against COVID, like any illness, than the general population?
No. And it's surprising. We don't really know why. But remember, one of the slides that I showed that one of the risks for poor outcomes were people who were not on disease modifying therapy. And we really don't understand that very well. But at least from the COVID-MS, the North American Registry, the folks who were not on DMT tended to do worse from COVID-19 infection than those who were actually being treated for their MS. So we got a little bit more research we need to do to understand that.
Sure, thank you. Bruce is asking, are MS patients more likely to get long COVID?
So the research is fairly new concerning long COVID, and so I've not seen any data that suggests that folks with MS or other autoimmune diseases are more likely to get long COVID, but we're just really at the beginning of understanding that. and kind of finding out about kind of what are the risk factors for long COVID.
Okay, thank you. Karen's asking, I've had a low-grade fever on and off since I had my first vaccination at the end of March. Could this be related to the vaccination?
So I always have to say, if you have any questions regarding your health, you got to talk to your doctor. That is not a side effect that I've heard of, that I've personally heard of or seen in the literature. But again, you know, this is all, as I said, subject to change on a regular basis. So, you know, certainly talk to your doctor about it, see if they think anything else is going on. We haven't seen that in the data so far, but, you know, I can't say 100% whether it is or isn't related.
Okay, great. Thank you for that. All right, back to Kay, since she's got an interesting question. All of them are interesting, but this is one that I've never seen before. What about patients with CD4 and CD8 counts under 200? What is the disease outcome if they get COVID, and will the vaccine work for them?
Hasn't been studied.
Okay.
Hasn't been studied. So if your CD4 and CD8 counts are less than 200, you know, meaning, you know, that your counts are low and you could potentially be more immunocompromised. We haven't really seen any data to suggest what that means in terms of outcome. What we do know is that when you think about many of our disease-modifying medications, people can often tolerate very low CD counts and not get infections, right? So there are many people who've been taking our medications, their counts are low, and they don't get sick, they don't get the flu, they don't have any issues. So what that translates to clinically, we don't really know. We certainly don't want the counts that low because we know there's a potential risk for increased infections, but we really don't have the data to say what that means kind of in a real clinical situation in any individual person.
Okay, thank you for that. Before we get to the last, I think, 5 or 6 questions, I want to remind everybody, please, that taken away from this program for a minute, I want to remind everybody that this coming Saturday, we're doing a virtual event. Dr. Boster will be speaking for that program, which was to be in Roanoke, Virginia, but because I'm from South Florida, the people from Virginia don't want me coming because of the Delta variant being so strong in Florida. I'm being banned from Virginia again. This happened a year ago at the same time. All right, and then on August 10th, we have a program that we're doing virtually. You'll have to go onto our website to find out what that is. We also have our PT programs on our Pilates programs and yoga coming up again in August, all right? And then on August 21st, I'll be in Greenville, South Carolina with Dr. Mary Hughes. I knew you would love hearing that. I knew you would love hearing that. And
my favorite.
We will be in Greenville, South Carolina doing a program live, okay, as well as virtually, okay? And again, it's with Dr. Mary Hughes and our Pilates instructor. She'll be on there as well, and it'll be an awesome program, all right? And hopefully we won't get banned from South Carolina. All right, Mark, or Mary rather, I don't know where I came up with Mark, sorry about that, Mary. Is there a recommended timing between the vaccine and your Ocrevus infusions?
So again, you know, talk to your doctor about it, right? Because there's really not a standard way of looking at it. There are many neurologists who say, get it when you can get it, right? Obviously, you probably wouldn't want to get the same day as your infusion, but, you know, ideally, it'd be nice if you had some time for your cells to grow back, like close to your next infusion, you know, but certainly just talk to your doctor about it and you guys can discuss the timing.
Great, thank you. Coy is asking, if a patient takes the vaccine months before starting Ocrevus, will the vaccine efficacy be lower?
No. I mean, so the concern with medications like Ocrevus is that you won't be able to mount an adequate response because some of your immune cells are wiped out. So if the vaccine is received prior to starting the therapy, unless you're on another therapy that wipes out your immune cells, actually you have a better response.
Okay, thank you. All right, let me just go through these questions real quick. All right. I, for one, can't wait to throw all the masks in the bonfire. When will we be finally able to do that? They make breathing difficult.
It's gotta be a wow.
and fog up my glasses. You know, they have anti-fog that you can put on your
They
glasses also,
do. They
right?
do. They do. Yeah, it's going to be a while, right? So cases are going back up, hospitalizations are going back up, deaths are going back up. And the more the virus spreads, the more ability it has to mutate, right? So viruses are smart. They want to stay alive. They want to evade vaccines and things of that nature. They want to spread. And so, as we have, these different variants develop, it's going to be harder and harder, for the vaccines to evade these variants. So it's going to be a while unless we have a significantly increased vaccination rate in the country and actually around the world.
That's very, very true. And that is good reason enough for all of you, if you've been vaccinated, to get those that you know that have not been vaccinated, to tell them why they should be vaccinated, because if they don't, they're just helping to spread this virus. All right.
Absolutely.
And going back to that, though, there's a lot of people that I know and that I've heard from others that they were vaccinated many months ago and they are getting COVID. And they're not severe. I haven't heard of any yet, personally, that are very severe, though I have heard about it on the news. And so does that go back to, again, the safety of being vaccinated, because we might get COVID, but it will be far less severe rather, than if we were not vaccinated? How do you respond to that?
So it's doing its job, right? So ultimately, we would love to prevent everyone from having COVID. If everybody was vaccinated, it probably wouldn't be able to spread, right? But again, as it continues to spread, it gets smarter and begins to evade certain things and become more contagious, right? So the goal of the vaccine is hopefully to prevent COVID, but to prevent severe COVID, right? So even if you get vaccinated and you get COVID, if you don't get in the hospital on the ventilator and die, the vaccine has done its job, okay? Because prior to the vaccine, many more people were going to the hospital, getting put on the ventilator and or dying. Okay, so it's doing its job. If you don't die of COVID and you don't have severe COVID, um, the vaccine has done its job, but it doesn't unfortunately prevent everyone from getting it 100%. And that also raises the question of, when do the antibodies start to go down, right? Are people beginning to get those infections because maybe they got vaccinated 6 or 7 months ago, and now the immunity is decreasing and we may need a booster? So there are a lot of questions surrounding it, but ultimately it's to prevent severe COVID.
Right. Thank you. Again, I'm going to remind everybody that had general questions about multiple sclerosis. That was not for tonight's program, okay? If you have those questions, please join us on Saturday, okay? You could go to our website, like I mentioned before. Join us on Saturday's program. Dr. Boster will be glad to answer those questions. If you don't want to hear from Dr. Boster, go to our YouTube channel, okay? We've had over 800 MS educational programs that are published to our YouTube channel. Type in the search field, type in your question, just a couple of words, all right? Like using keywords. And on those programs where those keywords appear, okay, will be the answers that you want to hear, okay? So you could do that one of two ways. You could join us for the program. You could use our YouTube channel. You can just go there and see, other doctors that have spoken about specific subjects. All right, now getting back to these COVID questions again. All right, Michelle is asking, well, this isn't directly also with the COVID, but she wants to see the slide again that you had for African Americans to register. And I know that's not relative to the topic, but it is, because Mitzi had it as one of her slides. Sorry, Dr. Williams had it as one of her slides today.
Yeah, I don't know. Bill will have to pull that up. With
Yeah,
the
it was
NAMSAR registry,
about 3 or 4 slides back, Bill.
3 or 4 from the end.
Right. If you could pull that back up again.
But until he gets it, the website is www.n as in Nancy, A as in Apple. There it is, namsar.org.
There you go. All right, Michelle, that's for you. All right. You asked me a few times, so there it is. All right. Next, we have a person asking, Celestine is, please discuss use of antibody infusion for patients, MS patients with COVID.
Yeah, so so there are antibody infusions that have been used to treat COVID-19. And so the use of those have also changed over time. So initially there was like a one-shot deal that you could get, but they recognize that you need to get like 2 of the infusions at the same time. So I haven't seen those used as much recently as we did in the beginning, because instead of being able to get one of those infusions, you really need to get both of them for them to be affected. And so there were issues with kind of people being able to get both of them at the same time.
Great, thank
But
you.
they
I
have
got
been
one.
shown to help COVID-19 infection.
Sorry, I always cut you off. I don't know why, but
That's okay. That's
you
okay. You're rolling. You're rolling.
you pause, and then I think you're done. So, okay, I start to shout out again. Thank you for these answers. All right, so we have one more question that I want to ask for sure, but I do want to thank everybody that is sending in their kudos. But Stewart is spelled S-T-U-A-R-T and not S-T-E-W-A-R-T, because that's a stewart. All right. So anyway, I do want to thank everybody that does recognize these programs for the benefit that you are getting out of them, and that is why we are doing this and many others. In fact, if you go to our website, you are seeing that we are doing 10 to 11 programs per month, and that's the way it will be through at least the end of the year, okay? And that includes classes on physical therapy, Pilates, and yoga. All right, the last question that I see is, what is long COVID? And this is by Nora.
Yeah, so long COVID is a term that applies to symptoms that can be very long lasting after an acute COVID infection. And so I think one of the things that people need to recognize, especially when trying to make that decision about getting vaccinated, is that COVID can be a long-term disease for many people. So there are people who deal with symptoms of fatigue, who deal with symptoms of brain fog, some of the same symptoms of MS, that can be debilitating. There are people who still have weakness, who can't function and do their jobs, people who are basically debilitated for very long periods of time, months and months after they get over the acute COVID infection with the fever. And so we're just beginning to understand long COVID and kind of the incidence rates of long COVID. Sometimes the symptoms are very severe, sometimes the symptoms are mild, but certainly can affect people for months after they get over that initial respiratory part.
Okay, thank you. I didn't want to overstep, but thank you. All right, so that's the end of our questions for tonight. And I do want to thank you for everything that you did. This was an awesome program. Like always, every time listening to you, it's an awesome program. So I thank you very much for that. And we did run a couple of minutes over. I do want to thank our sponsors, of course. We did mention them earlier. And I want to thank everybody that was on this program. I do hope that you will join us for our upcoming programs this Saturday and next Tuesday, and so many of the weeks following. All right, it's just a changing of the tide. Every week we do something different. Okay, and again, Dr. Williams, yes. And when I get to Atlanta in September, because we are doing a program in Atlanta in September on the 20th,
Come on and visit.
and I will come over to take a visit there as well. All right, everybody, Thank you for being here tonight. We look forward to seeing you at our next program. Join us, Dr. Williams. I can't wait to have you on another event. All right, thank you, everybody.
Thanks,
have
Stuart.
a great night. See y'all.
Have a great night, everyone.